Today we are going to talk about bleeding and lots of bleeding, and especially in the context of the gastrointestinal tract, the GI bleeding or the gastrointestinal bleeding. All right. In order to understand the gastrointestinal bleeding, it is easy to divide the whole gastrointestinal cavity into the two tracts, the upper GI tract or the upper gastrointestinal tract and the lower gastrointestinal tract. Now, where is the demarcation between the upper gastrointestinal tract and the lower gastrointestinal tract? We generally characterize upper GIT, right, starting from the mouth, then the esophagus, then the stomach, and then involving the duodenum. And onwards from the duodenum after the ligament of Treats, which is generally present at the duodenum and the jejunum flexure or the duodenojejunal flexure. Proximal to the ligament of Treats, it is all characterized by upper GIT, and distal to the ligament of Treats all the way up to the anus or in the rectum, it is characterized into the lower GI tract or the lower gastrointestinal tract. Now, the reason for this characterization is, number one, it makes it easy to classify the various pathologies that involve the gastrointestinal tract, and number two, the presentation is slightly different of both the compartments. As you know that the stomach has acid, so any bleeding proximal to the duodenum will definitely be hampered by its consistency will be hampered by the acid. And that shows, for example, the characteristics of the upper GI bleed are hematemesis and melena. Hematemesis, as you know, as the blood in the vomitus. It can be fresh blood or it can be clotted blood. And the second part is melena. Melena is defined as black, tarry, foul-smelling stools. Now, why are these stools black in consistency, you may ask? This is because when there is bleeding proximal to the ligament of Treats or in the upper GI tract, for example, in the stomach, or there are some esophageal varices, the blood comes in contact with the acid, and that alters its consistency and makes it a bit clotted and alters the protein consistency in the blood. So that's why that blood presents in the form of melena or black tarry stools. So the characteristics, this is generally speaking and broadly classifying, the characteristics of the upper GI bleed, the hematemesis and the melena, and distal to the ligament of Treats, generally we characterize the bleeding as hematochezia. Hematochezia means blood coming out of the rectum. So this can be profuse bleeding, this can be very slight bleeding. There is another term used to generally define bleeding in terms are the occult bleeding or the overt bleeding. Now, what does these terms mean? Occult means literally in English language, it means hidden. So occult bleeding is some bleeding going on in the body, or in this matter the GI tract, which is not visible to us. It doesn't come out of the anus, it doesn't come out of the mouth, and it is generally symptomatic. So with the help of the symptoms and the patient suffering from various signs and symptoms, which we are going to discuss in the next slide, we classify that bleed as the occult bleed, whereas the overt bleed are the other bleeds which are visible to the human eye. For example, as I just talked about, the hematemesis, melena or hematochezia, these are the overt bleeding. These are visible and apparent. So it is important to characterize the GI tract into this upper and the lower part to just understand the pathologies much more comfortably. Now, just as I was talking about, let's look at the various clinical manifestations that a patient with GI bleed can present with. In case of occult bleeding, where there is no visible bleeding, then the patient generally presents with symptoms of hypovolemia or loss of the volume. And these may be anemia, as you know, angina. The patient can present with chest pain. If there is visible or overt bleeding, then there are bloody stools, as we can say. It might be in the form of melena if there is upper GI bleed, or it might be hematochezia. In case of the lower GI bleed, there will be dyspnea because of the lack of the oxygen to transport the lack of the hemoglobin to transport the oxygen. So these are the classic signs and symptoms of anyone which has bleeding, or anybody who is in hypovolemia. The anemia, angina, dyspnea, fainting. The person might have such low hemoglobin concentration or the oxygen carrying capacity that he or she might have some syncope, dizziness, or he or she might faint because the blood is unable to reach the brain, or the volume has gone down so drastically that we are unable to stay conscious or perfuse the brain adequately. So these are the classic signs and symptoms of hypovolemia, along with in the occult bleeding. In the overt bleeding, we will have either hematemesis or melena or hematochezia, and the blood will be visible, and that will be much easier for us to classify. In case of occult bleeding, we have to look at the various causes by ruling out step by step and doing various procedures like upper GI endoscopy or the colonoscopy to find the visible source of bleeding. And if we don't find a source of bleeding, then there are certain other investigations which we do, which we are going to talk about in the latter part of this lecture. Similarly, as I told you, hematemesis, bloody vomiting, it is also a manifestation of GI bleeding, specifically upper GI bleed in this context. All right. So based upon our initial classification, let's just revise it. The upper GIT generally consists of from the mouth to the including the esophagus, the stomach, and the upper part of the small intestine, which is duodenum. Distal to the duodenum, which involves the jejunum, ileum, various parts of the colon, ascending, transverse, and descending colon, the rectum, and the anus, we generally classify as into the lower GI tract. So the lower GI tract generally involves both the small intestine, major part of the small intestine, and all of the colon and the latter parts. Now, let's talk about upper GI bleed first. As I told you that the major presentations of the upper GI bleed are the hematemesis or the melena. But these are apparent when there is very profuse bleeding. Generally, most of the times there is some bleeding going on and it is not very much visible, and it 60 to 70% of the time, if there is a minor bleed, it resolves on its own and we don't have to do anything. But let's look at the various important causes of upper GI bleed. About 50 to 60% of upper GI bleed is because of the peptic ulcers. As you know, this is the most common cause of upper GI bleed, and it can present in various forms. For example, if there is a duodenal ulcer, it is bleeding, and it can lead to hypovolemic shock because the gastroduodenal artery might be compromised, and there might be profuse bleeding in these patients. So these patients, what are the reasons of peptic ulcers? As you know, the most common causes are three you have to remember: non-steroidal anti-inflammatory drugs, H. pylori, or increased acidity. So these are the three basic causes of causing ulcers. Peptic ulcers, it generally includes the ulcer in the duodenum or the ulcer in the GI, in the stomach. The ulcer in the stomach is more likely to transform into the carcinoma, while the ulcer on the duodenum is more likely to bleed or perforate. And that depends on the anatomy, whether it is an anterior part of the duodenum or the posterior part of the duodenum, or whether it involves the artery or not. So this is a very important pathology, and peptic ulcers are fairly common because of the increasing use of the non-steroidal anti-inflammatory drugs by patient over the counter. And these can also develop in certain patients in the form of stress ulcers. Apart from the major three causes which I just talked about, there can be some stress going on. For example, there are various variations like the Curling's ulcer or the Cushing's ulcer in the patients with burns or patients with head injury. So in those patients, we also provide the protective coverage to those patients in the form of proton pump inhibitors or the H2 blockers. We are going to talk about the treatment modalities in detail in the last part of the lecture. So as for now, we have to go through the various important causes of the various types of bleeding. So peptic ulcers constitute about 50% of the upper GI bleed. Second in line are the Mallory Weiss tears. Now these tears are produced generally in the lower part of the esophagus or in the esophageal-gastric junction, the upper part of the stomach. So the distal esophagus and the proximal stomach are the major parts where these tears are present. And why do they form? They are generally formed in alcoholics. Because of alcoholics having a lot of alcohol, they get drowsy and they start retching or they start vomiting, and these lead to increased pressure in the lower esophageal sphincter and lead to these tears. And these patients can present with profuse bleeding in the form of hematemesis. More likely hematemesis is a presentation rather than melena in these patients. Similar to the peptic ulcers, hematemesis is the major presentation. But 60 to 70% of the Mallory Weiss tears are generally self-controlled. There isn't very much bleeding, profuse bleeding, to cause any medical emergency. So in the context of Mallory Weiss tears, all you have to remember is retching, which leads to increased intragastric pressure, the vomiting, hematemesis, and these tears are generally healing. And if there is some profuse bleeding, then we have to do some endoscopic interventions to fix these Mallory Weiss tears. So these peptic ulcers and Mallory Weiss tears, along with the esophageal varices, these three constitute about 75 to 80% of the causes of upper GI bleeding. So these are the ones to rule out first, and these are the ones that can cause life-threatening hemorrhage. So we have to study them in detail and remember them in context of the upper GI bleeding. Let's talk about the esophageal varices a bit. You know how are these esophageal varices formed? These are formed in the context of someone with chronic liver disease, someone with cirrhosis and portal hypertension. It can lead to the dilatation of these varices at the junction of the esophagus and the stomach. And in the esophageal, whenever a patient with esophageal varices present, then this patient can bleed to death. This is a serious medical emergency. If you have a patient with chronic liver disease or someone with cirrhosis and he presents to your ER with profuse vomiting and melena, hematemesis or melena, you have to look into the esophageal varices first and have to go and scope that patient and try to fix it, because this is most likely the pathology going on. And there are various interventions which you can do. There are some medical treatments as well. But as I want you to remember that this is a medical emergency. If a patient presents with bleeding esophageal varices, you have to act quickly. Preferably, these patients should be scoped within 12 hours of presentation into the ER. As early as possible, the better. If you intervene the earliest, you might save that person's life or save a lot of bleeding. And then you have to look at the bigger picture when the patient gets stable, that why is this patient bleeding because of the varices. You have to look at the status of the cirrhosis or the condition of the liver and how you can do to prevent the recurrence of bleeding in these patients. Because fixing the bleed is one part, and these patients, especially the patients with peptic ulcers and esophageal varices, they are very likely to rebleed. So after fixing the pathology in the first place, you have to then, the next step comes there is to prevent the rebleed, because the rebleeding is a very common phenomenon, especially in these patients. And then there are various interventions which we'll discuss later on, what can we do to prevent the rebleed in these patients. Similarly, hemorrhagic and erosive gastropathy, or in other words, it is called gastritis. This is basically an inflammation of the mucosa, inflammation of the gastric cavity, specifically the stomach. The major causes here are, again, non-steroidal anti-inflammatory drugs, or someone who is an alcoholic, or someone who has hyperacidity. These are the basic three causes, similar to the peptic ulcer. So it can present in the form of gastritis, and if it is chronic, it can get transformed into an ulcer. Similarly, as you know that in the mucosa there are no arteries and the veins, they're majorly capillary. So these patients don't bleed too much. There are slight bleeding, but these are very unlikely to cause life-threatening hemorrhages. But if there is continuous bleeding and the patient is having anemia or syncope or dyspnea, then you'll have to go and fix these erosion. Otherwise, the major treatment for them is avoidance of the non-steroidal anti-inflammatory drugs as much as possible, or if it is not possible to avoid it, then we replace it with the gastroprotective non-steroidal anti-inflammatory like the celecoxib, and then we provide a PPI cover as well to these patients, and these lead to the decreased incidence of rebleeding in these patients. And similarly, we counsel the patient to cut down on their alcohol intake and take care of the other things going on, manage their stress as well, because stress, as I told you, can, as it leads to peptic ulcer, it can also lead to this gastropathy, specifically in someone who is having has increased intracerebral pressure, or someone who's gone through a trauma or burn, or any chronic illness, like someone who is immunocompromised, diabetic, and who's taking a lot of medications. All the stress of that on the human body, that can cause this gastropathy. And we provide the PPI cover in those patients as well. But generally in these patients, it can be a troublesome thing to deal with. And we have to provide the cover of the proton pump inhibitors in the context of the other medication going on. And these are the patients which generally have a poor prognosis if they are terminally ill. In healthy patients, if he's taking NSAIDs, for example, osteoarthritis, and generally the patient is in good health, then we can somewhat manipulate the drugs and prevent this gastropathy from developing or recurring. So I want you to remember these four as the major causes of the upper GI bleed. Peptic ulcers are the most common, followed by Mallory Weiss tears, esophageal varices, and the hemorrhagic and erosive gastropathy or the gastritis. Now, just for the matter of completion, let's just quickly go through some of the other causes. These are very rare and very unlikely for you to encounter these in your general practice. So, erosive duodenitis, which is inflammation of the duodenum, it can present with upper GI bleed. There can be certain neoplasms like the gastric adenocarcinoma, aortoenteric fistulas, which are fairly uncommon. These can present with upper GI bleed. There can be some gastric antral vascularitazia, some malformation of the vessels, which can profusely lead to the upper GI bleed. And in this case, we have to go and fix the patient by an angiography. We have to do angiographic ligation if there is a major life-threatening bleed. And prolapse gastropathy is another condition, and hemophilia is another condition. So these are some rare causes of upper GI bleed. Now let's go through the small intestinal bleeding. The small intestinal bleeding, as you know, contains three parts: duodenum, jejunum, and ileum. So it has one part of the upper GIT and two parts of the lower GIT. So it can present with either melena or hematochezia. But majority of the time it presents with hematochezia, or it can also present with occult bleeding, which is fairly common, especially in context of the small intestine tract. We are unable to locate the source of the bleeding. We are going to talk about it in the coming slides. Let's look at the various types of the various causes of the small GI bleed. The most common ones are the vascular ectasias. There is any vascular malformation or any fistula or any abnormal dilatation of the vessel in the small intestinal tract. For example, the superior mesenteric artery malformation or anything like that, it can lead to a small intestinal bleed. And this bleeding can present with hematochezia, or most likely because of there is a lot of distance, and if it is a small bleed, it can present as occult bleeding. This is the most common cause of bleeding, especially in adults, patients who are generally more than 50 or 60 years of age. Vascular ectasia is the number one cause. Then there are certain small intestinal tumors like the gastrointestinal stromal tumors or the lymphomas that can present with small intestinal bleed. There can be some carcinoid tumors, which are fairly rare, but these are the common causes of small GI bleed. Certain erosions, like because of the non-steroidal anti-inflammatory or someone who is taking a lot of alcohol, and these erosions can also transform into the ulcers. These are the most common causes in adults, you can say. The fairly less common causes are Crohn's disease. Crohn's disease is less common overall cause of small intestinal bleeding, you can say, but it is a fairly common cause if someone who is presenting with small intestinal bleeding in adolescent age or as a young child. For example, if someone is 20 to 30 years old, then you have to rule out Crohn's disease, because Crohn's disease generally affects this age population. So in the adults, you are going to look at the vascular ectasia. Then someone who is fairly young, you have to look at the Crohn's disease. And as you know, Crohn's disease is part of the inflammatory bowel disease. There is Crohn's disease, and then there is ulcerative colitis. Crohn's disease is the one which can affect any part of the GI tract. Ulcerative colitis generally involves the colon and moves proximally. We are going to discuss these pathologies in the relevant lectures in details. Similarly, if there is any infection of the small bowel, it can lead to this small intestinal bleeding. But this is also fairly uncommon, as infections of the small bowel are not very common, and they are more likely to present with other presentations like fever or pain. It might also perforate. So bleeding is a fairly less way of presentation, but you have to remember it in the context of small GI bleeding, especially if, specifically if there is some ischemia of the bowel or some volvulus going on which obstructs the bowel. There is some vasculitis, inflammation of the vessel, which generally vasculitis is a diffuse term. It involves various organs and various parts of the body, and there are various types of vasculitis. And if it involves a small bowel, it could present with a small GI bleed in the form of hematochezia. Similarly, varices can form in small intestine, which is fairly uncommon. They are generally formed in the esophagus and in the rectum, as you know. Diverticula is a common cause. It is more likely cause of bleeding in the colon, but there can be some small intestinal diverticulum as well. duplication cysts can form. And then intersusception, as you know, what is intersusception? It is telescoping of the one segment of the bowel into another, and it is a common cause of uh, pain, the gastric pain, the pain in the abdominal cavity, especially in the young children or the pediatric population. It is fairly uncommon in the adults, but intersusception is an important cause. And then, talking of the children, the most common cause which you have to remember, and it is Meckel's diverticulum. And if a child comes with a small intestinal bleed, then the number one thing you have to rule out is Meckel's diverticulum. As you know, it is an outpouching of the small bowel, just uh, proximal to the ileum and the colon junction, and it is present in 2% of the population. The rule of 2% of the population, and 2 times it is symptomatic. 2% of the time it bleeds, and it has it can also have various gastric tissue as well, which can lead to the ulceration and formation of an ulcer in this diverticulum, and it can also mask down appendicitis in a young child presenting with the right iliac fossa pain. So Meckel's diverticulum is a fairly common cause of small intestinal bleeding when it comes to children. And then if an adolescent comes, then Crohn's disease and infection are the ones which you are majorly looking at. If someone who is just generally on the 50s and 60s and presents in the adult population, then vasculectasias are the ones which you are going to rule out, and certain rare tumors as well. Now, that was all about the small bowel. Let's look at the large bowel or the colon. What are the various causes of bleeding in the colon? By far, the number one causes of bleeding in the patient with colon problem are the hemorrhoids. You know, these hemorrhoids are the dilatations of the veins in the submucosa, especially presenting in the rectum. There are two parts, the external and the internal. The external hemorrhoids generally bleed. Internal hemorrhoids generally present with thrombosis, and these can cause a fairly fair discomfort to the patient, and these can cause a fair amount of bleeding. And these are pretty much a clinical diagnosis. You examine the patient, and you can see the external or the internal for example, if the internal hemorrhoid is fairly large, it generally causes thrombosis, and this is the time when it causes symptoms. So this hemorrhoids are generally the clinical diagnosis, and this is the most common cause of bleeding because of the increased incidence of hemorrhoids in general population. It is regarded as the most common cause of colonic bleeding. Similarly, there can be an anal fissure. As you know, anal fissure is generally a fissure or an opening or a cut in the anal cavity. And the number one thing which a patient with anal fissure will present is intractable pain. The patient won't be able to sit properly. There will be a lot of pain, and the patient will say that, especially when I defecate, I cry with pain. And when you just examine the patient with the help of a proctoscope, you can easily find an anal fissure, and this is fixable with the help of various medications or creams or ointments. But it can also present as colonic bleeding, but most commonly it presents with intractable pain in the anal area, and the patient presents with difficulty in passing the stool or very painful defecation, you can say. Similarly, diverticulum, as you know, here is a diverticulum. This is an outpouching of the bowel. This is another very common cause of the colon bleeding. Outside of the hemorrhoids, this is the most common cause of bleeding in the patient with most common cause of lower GI bleeding, as you can see, especially in the middle population. Why are these diverticuli formed? You may ask. These diverticuli are generally outpouching of the bowels, and these are generally formed in patients who take a lot of meaty diet, or a lot of beef, and someone who take very less fiber. This leads to increased stress on the bowel, and on the long term, if patient is not taking a lot of fiber and taking a lot of meat heavy or protein heavy or fat heavy diet, this can lead to this outpouching of the bowels in the various compartments, and they generally present with bleeding. They are more common on the right side of the colon than on the left side, and they can also present with occult bleeding. And when we do a colonoscopy, then we can find these diverticuli, and then we can look what we can do with them, whether they're infected or not, and how are we going to fix them. Similarly, whenever a patient more than 50 years of age presents with a lower GI bleed, or presents with occult bleeding, or presents with anemia, unexplained anemia or syncope, then the number one thing you have to rule out is colon cancer, because it is getting fairly common, especially if someone who has positive fecal occult blood test, which we are going to talk about in the coming slides. Someone who has lower GI bleeding or hematochezia, and he's about 55, 60 years old, and there is you are unable to find a cause of bleeding, then the number one thing to rule out is colonic adenocarcinoma. It is getting increasing common because of our eating habits, because of obesity, and majorly it is an adenocarcinoma of the colon, and it can present with bleeding. It can also present with the lower GI pain because of thrombosis. So this is also becoming an increasingly common cause of colonic bleeding, especially in the context of the adult population, or if someone who has a history of a relative with colonic adenocarcinoma, and there are some genetic diseases going on, then you have to lower your suspicion level according to the age. For example, then if a patient who is 35 or 40 years old with a first degree relative of colonic adenocarcinoma, then you have to put this higher in the differential diagnosis, because there can be some genetic association going on, and you have to rule out neoplasms. And even if you don't find a neoplasm in that patient, you have to do serial colonoscopies after certain intervals to keep a check on what is going on in the colon, because these patients are more likely to develop adenocarcinomas of the colon as compared to the normal population. Similarly, colitis is any condition which causes inflammation of the colon. As you know, all this redness and edema is inflammation. This can be ischemic colitis, this can be ulcerative colitis, can be because of any reason, or a bacterial infection or anything. And this can also present along with the other features of inflammation like pain or redness. It can also present with the bleeding as well, specifically in the context of ulcerative colitis or ischemic colitis. So whenever the patient with colitis, there will be other signs and symptoms which will move you to the diagnosis of colitis. So this is also a common cause of colonic bleeding. And then a fairly rare cause is a post-polypectomy bleeding. If the patient had some polyp and you extracted that polyp, then post-polypectomy there might be some minor bleed. But the important ones to remember here are the hemorrhoids, anal fissure to some extent, diverticulae, and neoplasms in the context of adult population or someone with a higher degree of suspicion, like a genetic association with first degree or relative. So these are the causes of the colonic bleeding. Now, after talking about the more common causes, let's look at a few rare causes of the colonic bleeding. There is a rare condition called rectal ulcer syndrome, which can lead to colonic bleeding. Similarly, there can be some trauma varices or rectal varices, which can lead to the colonic bleeding. The lymphoid nodular hyperplasia, if there is some lymphoid abnormality or hyperplasia of the lymphoid tissue, it can rarely present with a colonic bleeding. Vasculitis is also a very rare cause of colonic bleeding. For example, you can say like a condition called Henox-Corlin purpura. In children, it can present with a colonic bleeding. Aortic fistulas, just like the aortic and direct fistulas, if there is a aortocolic fistula, that can present with the lower GI bleed, or specifically the colon bleed. Inflammatory bowel disease, as we just talked about in the previous slide, it is a type of colitis, especially the ulcerative colitis, which affects the lower GI tract or the colon specifically. This can present with the colonic bleeding. And this is among the, you can classify them as among the fairly common cause, or somewhat which comes right in between the rare causes or the most common causes. The most common causes are the ones which we talked about in the previous slide, and these are fairly the rare causes. Juvenile polyps, especially in the context of children. If a child has colonic bleeding, then you have to look out for a juvenile polyp, or you have to look out as a Makers diverticulum. These are the most common causes of lower GI bleeding in a child. All right. These were the causes of various types of bleeding, the upper GI and the lower GI. Now let's look at how we are going to approach the patient coming to us with a GI bleed. First, let's have an overview of how we are going to go through. The number one thing to do is initially assess the patient. Is the patient hemodynamically stable? You have to check the BP, the pulse, whether there is tachycardia or signs and symptoms of hypovolemia, like the patient is cold, clammy, or unconscious, or the patient complains of chest pain. These are the initial assessments, because if a patient is unstable and coming to the ER, then the number one priority is to resuscitate the patient and make sure that the patient doesn't collapse. And if the patient is stable, then we can proceed with our regular investigation and treatment. Then we have to differentiate, after stabilizing the patient, we have to differentiate the upper GI bleed from the lower GI bleed. Broadly speaking, you know that the upper GI bleed is generally presents as hematemesis or melena. The lower GI bleed generally presents as hematochezia. But there can be certain conditions in which the lower GI bleed can present in the form of melena as well, or if there is some upper GI bleed that can present with hematochezia, specifically if the blood is passes through too quickly through the upper GI tract, that it is unable to be modified by the acid. But they are fairly rare. But if a patient has a profuse lower GI bleed, and then we have to look at that whether this or if a patient has profuse hematochezia, you can say a lot of blood is coming out of the anal cavity, then we have to consider this option of hematochezia being caused by an upper GI tract problem, because the lower GI bleeds generally are not very profuse. They are very chronic conditions, as you have seen, or they are very minimal in amount. There are very rare conditions causing profuse lower GI bleed or profuse hematochezia. So as we are going to see in the coming slides, if there is profuse hematochezia, then we have to do upper GI endoscopy as well to rule out any cause of the upper GI tract causing this hematochezia. But in a broadly terms, to differentiate the two, upper GI bleed you have to remember as hematemesis and melena, and the lower GI bleed you have to remember as the hematochezia causing this lower GI bleed. Now, similarly, if we have identified that this is an upper GI bleed, then we are going to evaluate it and manage it. Or if we have identified the cause as a lower GI bleed, then we are going to evaluate and manage it in certain ways. These are all. This is an overview, and we are going to discuss all of these in the coming slides. And if we are unable to find a source of bleeding, then we classify that as an obscure GI bleeding. And there are certain protocols which are followed in the evaluation and management of obscure GI bleeding. We are going to go through them. And then there is, we are going to talk about the fecal occult blood test in the context of the colon carcinoma in the latter part of the slides. So this is an overview of how we are going to proceed with the management of the patient with a GI bleeding. Now, let's look at the initial assessment. When a patient comes to you let's talk about it that you are working in an ER of a busy hospital, and a patient comes to you with GI bleeding. The number one thing is the normal protocol. You passed an IV line. If the patient is hypoxic, you give him oxygen, you monitor the vital signs. And the number one thing to look for is whether the patient is stable or not. If the pulse is fine, the patient is looking well, you don't find any hemodynamic instability, and the patient is fairly stable, there is no hypoxia or no chest pain, but there is some bleeding going on, and the vital signs are stable, then you are going to proceed with your management as follows. Then, the first part is to characterize whether this is an upper GI bleed. As you know, the upper GI bleed presents with hematemesis or melena, or whether this is a lower GI bleed, in which case it is presenting with hematochezia. If the patient presents with hematemesis or melena, then stepwise and anatomically we have to rule out the various causes. The most common causes, as we know, are the ulcers, peptic ulcers. And but we have anatomically, if we go from the mouth and we scope the patient, do endoscopy in the esophagus, we have to rule out the esophageal varices, because it is a fairly common cause and it can cause some life-threatening bleed, and the patient might be stable at presentation, but these patients with esophageal varices can bleed to death, and they can transform from being stable to unstable in a matter of minutes. So you have to rule out the esophageal varices, especially if the patient has some cirrhosis or liver pathology going on, and you suspect that there might be some portal hypertension, if the patient has ascites as well, and if the patient or if the patient has any hepatic encephalopathy or previous history of all this, then you have to look out for the esophageal varices in the esophagus examination. They can be esophagitis or the aortic enteric fistula, Mallory Weiss, especially in the context of an alcoholic, and he presents with hematemesis and retching. And in the stomach and the duodenum, peptic ulcer is the number one cause which you have to look at and examine the ulcer if there is present, whether it is bleeding or not, what is the base of the ulcer. There can be erosive gastritis, especially if the patient has some trauma going on or some chronic medical illness. And there can be certain malignancy if there is weight loss and the patient has a history of gastric ulcer, as gastric adenocarcinoma is generally formed by the gastric ulcer later on. So these are the types, various causes of upper GI bleed which we have to rule out in a stable patient. We generally do endoscopy to do that, and we are going to talk about it in the coming slide. Now, if the patient presents with hematochezia, then all we have to do is look at the small bowel and colon and the anorectal. The small bowel causes are fairly uncommon. So we scope the patient from downwards now with the help of a colonoscope, and we have to rule out the various causes. The visible causes are, without scoping, are the ones you can see on examination, like the hemorrhoids or the fissure. But if the hemorrhoids and fissure are not present there and the patient is still bleeding, then we have to do a colonoscopy or a sigmoidoscopy to look at what is going on in the patient. There might be some diverticulosis, as you know, it is a common cause. Malignancy is fairly common. There can be some colitis, ischemic colitis, or ulcerative colitis, or Crohn's disease might cause it. The angiodysplasias are the fairly common causes, especially in the context of the lower GI bleed when it comes to the small intestinal tract. And if there is some vascular pathology like the vascular ectasia or the angiodysplasias, then they are more likely to be fixed by the help of an angiography. We do an angiography, we examine the various arteries. If there is an abnormality, then the dye might spill into the colon or small intestine, and there we can fix it with the help of an embolectomy as well. So in a stable patient, these are the various causes which we have to rule out. And how we are going to do it is will be discussed in the coming slides. Now, if the patient is not stable and you examine the patient and you see that the patient is hypoxic, or the patient has tachycardia, or the patient's blood pressure is falling and it is very low, and you see that the patient is not feeling well and he has cold, clammy skin, or all the signs of hypovolemia are present here, then what is the management? In such a scenario, the number one priority of a doctor is to stabilize the patient. We have to make the patient go here. We have to stabilize the patient because these can be some life-threatening hemorrhage, and this can lead to even the death of the patient. So what is the management in that scenario? In this scenario, we follow the basic protocols of hemodynamic stability. If there is massive bleeding and the patient is profusely bleeding, whether there is melena or hematochezia or hematemesis, then specifically if there is hematemesis, we can consider tracheal intubation if endoscopy is not possible. And if the patient is hypoxic, the saturation is going low, we have to provide him with supplemental oxygen. If the patient has altered mental status and he can aspirate, then in that condition, we can also consider that tracheal intubation and secure the airway to prevent the aspiration. And the basics of the resuscitation will be followed. We will maintain the volume of the patient with the help of some crystalloid infusion like ringer lactate. We could consider the blood transfusion if the hemoglobin is less than 7 and the patient has a history of bleeding as well. In the elderly chronic arterial disease, this threshold is increased, and we generally transfuse the patient with even 9 milligrams per deciliter of hemoglobin in the elderly or someone who has some chronic artery disease going on. If there is some coagulopathy going on, we have to reverse that with the help of anticoagulants. If this thrombocytopenia, then we transfuse platelets in the patient because these patients can also bleed to death, and this can be a medical emergency. So the basics of the resuscitation which you follow in the ER are generally followed in this case as well. Similarly, if we consider that if we have a higher degree of suspicion that the bleeding is because of a peptic ulcer bleeding or any type of gastritis because of hyperacidity, then we can immediately start off a PPI infusion in this patient. We can give a large bolus initially, and then we can give the patient an infusion set at a certain dose hourly. This is specifically because you know that whenever the patient presents with a massive upper GI bleed, like someone who is having a massive hematemesis or melena, and there is no history of compensated liver disease, but there is a history of NSAIDs intake or history of alcohol, then the number one cause, as 50% of the time it is the peptic ulcer. So in this context, if you have a higher degree of suspicion, even before endoscopy, you can start a PPI infusion and then scope the patient and see if there is visible bleeding, and you can fix it. Similarly, if degree of suspicion is high for a variceal bleed, like someone with a liver disease going on, then you can provide octreotide infusion in that patient initially before swapping the patient. And prophylactic antibiotics are also given in cirrhosis to prevent the infection. These are also helpful. These two mayas in a cirrhosis patient are also helpful in preventing the rebleed in these patients. And then after stabilizing the patient, then we go through the and scope the patient with the help of an endoscope and look at what we can do. The endoscopy can be diagnostic if we are unable to diagnose the patient on clinical presentation, and can also be therapeutic. We can, for example, in someone with a bleeding varices, we can do sclerotherapy or coagulation or banding of the varices, or in someone with a peptic ulcer disease, we can go and coagulate that bleeding artery as well. So endoscopy is generally the gold standard which is followed in this bleeding, generally up in the upper GI bleed patient, and there is a diagnostic procedure as well. If there is a minor bleed, then we can diagnose it and then we can medically manage it. If there is a large bleed, then we can even fix it with the help of banding or sclerotherapy or the various procedures which we can do with the help of an endoscope. This is a generalized approach to the patient. Just remember the stability of the patient, hemodynamic stability overrules everything. If you have a patient who is profusely bleeding and there is life-threatening hemorrhage, the number one thing to do is to stabilize the patient. Consider tracheal intubation, resuscitate the patient, start pharmacotherapy, or then afterwards, when the patient is stable, you can go and scope the patient. Just as I told you, the endoscopy is the operative management, and even we can do advanced imaging with the help of an endoscope. If we tie an ultrasound device at the end of the endoscope, we can get a fairly good idea of what's going on in the esophagus and the adjoining areas as well. And the upper GI endoscopy involves the visualization of the esophagus, the stomach, all the way up to the duodenum. So this generally covers all the areas of the upper GI bleed. All right, now let's look specifically at what we have to do in context of the upper GI bleed. In an acute upper GI bleed, the number one cause is the ulcer. We are going to talk about it in detail in the next coming slide. Let's look at the other causes. As I told you, esophageal varices are the second or the third most common cause, and the Mallory Weiss tears are the other common cause. These are the major three causes of the upper GI bleeding. Now, if you have a patient with esophageal varices, for example, a patient with a chronic liver disease or patient with a cirrhosis presenting with hematemesis and melena, what you can do is, if there is a higher degree of suspicion, you can start an IV vasoactive drug like an octreotide right away in the patient. This will help in clamping down the varices and slightly causing vasoconstriction and leading to the decrease in the bleeding slightly, so that you can scope the patient. Then after securing the airway, if you can scope the patient, after stabilizing the patient initially, and the patient gets slightly better hemodynamically, then you go and do an endoscopy. Preferably, an endoscopy should be done as soon as possible. It is mandated to do it within 12 to 24 hours of the presentation of the patient to avoid the mortality, because these patients can bleed to death, as I told you before, and this is a medical emergency. So you do and do endoscopy, and with the help of the endoscope, you can ligate those bleeding varices via sclerotherapy or banding, and can cut down on the bleeding. And then we continue this vasoactive drug for 3 to 5 days. And the patient, this patient generally remains in the ICU initially for the first 1 or 2 days. He's closely monitored for rebleeding, and then he can be transferred to the ward in the next 2 to 3 days. But there is a large incidence of rebleeding in these patients, especially if the portal hypertension is very high and there is end-stage cirrhosis in this patient. So there are certain other options also available for these patients. After acutely managing the patient, the second priority is to prevent the rebleed. Then we start the patient on certain beta blockers, for example, propranolol chronically, or we can also look at certain procedures like TIPS or the transjugular intraportosystemic shunt in patients who have a large degree of cirrhosis or someone who has a lot of portal hypertension, and this esophageal varices occurs fairly regularly in such patients, then these procedures can be looked into going forwards to prevent the recurrence. But acutely, what you have to do is ligate the bleeding varices and give an IV vasoactive drug like an octreotide. If a patient presents with Mallory Weiss tears and if there is active bleeding, then again you have to go through the endoscopy and look at the bleeding site and fix it with the help of an endoscope. But active bleeding and profuse bleeding is generally uncommon in patients with Mallory Weiss tears. Generally, the patient presents with a slight degree of bleeding, and 70 to 80% of time that bleeding resolves on its own. But if there is active bleeding and the patient is not hemodynamically stable, then you stabilize the patient and go through the endoscope to look at what is going on. And then with the help of an endoscope, you can fix that bleeding there and then. And then you can monitor that patient for a couple of days in the hospital. Afterwards, he can be discharged. But if there is no active bleeding, there is no need of endoscopic therapy. You just monitor that patient and discharge that patient. And if the occurrence is fairly common or the patient presents with active bleeding, then you can go and scope the patient. All right. We've talked about the varices and the Mallory Weiss tear. Now let's look at what is going on. If we have a patient with a peptic ulcer and he presents with bleeding, number one thing, if there is active or profuse bleeding and you scope the patient and there is a visible vessel, for example, a gastroduodenal artery bleeding, the number one thing to do is to, with the help of an endoscope, you coagulate that artery or do sclerotherapy, or you stop the bleeding with the help of an endoscopic therapy. And along with that, you provide a PPI cover. You can give a bolus of a PPI initially, for example, 80 mg, and then follow it up with 8 mg plus per hour for the next 12 hours or so. So, and then afterwards, when the patient is discharged, he is discharged on the PPIs, and this patient has a close follow-up to prevent the recurrence of bleeding. And if there is any preventable factors like the NSAIDs use or the H. pylori use or the alcohol use, and then we have to modify these factors to prevent the recurrence of ulcer formation or the recurrence of the bleeding. These patients again with profuse bleeding are monitored in the ICU initially, and then they can be transferred to the ward. If the patient presents and you scope the patient and there is an adherent clot, then it is questionable that whether the endoscopic therapy is helpful or not, because the clot can rupture with the help of, if you start going deep into the endoscopic therapy. In those patients, generally a conservative management is followed. We provide an IV PPI cover, and then we look at the risk and benefit ratio considering the patient's overall health of endoscopic therapy or not. But these patients are again closely monitored. They can be retained in the ward for 2 to 3 days to prevent bleeding from that adherent clot. If we do an endoscope and there is no bleeding, but we have a flat or a pigmented spot, then there is no need of any PPI or endoscopic therapy in this patient because the patient isn't bleeding. And these patients can be retained in the ward for a couple of days to have a close monitoring, but generally they can be discharged on oral PPI drugs and certain lifestyle modifications like the management of the stress or reducing the alcohol intake, or there's a history of H. pylori, then you can do the H. pylori eradication theme in these patients. But there is no need of endoscopic intervention or IV therapy in these patients. And if you have a clean base ulcer with no bleeding visible, then similarly to the last point, there is no need of any endoscopic intervention in these patients. And you can discharge the patient or manage this patient in the OPD department. So this is a very nicely put management of the ulcer in the context of bleeding, and goes from one extreme to another, and it is very helpful to remember specifically for exams and as well as for your medical practice. Now let's go through the lower GI bleed and its treatment. I'm going to play the slide completely because otherwise you will get a bit confused, and then after which we have played the slide completely, we are going to stepwise break it down and look at what is going on here. All right. Now, if a patient presents with acute lower GI bleed, similar to the first point, number one thing to look at is whether the patient is hemodynamically stable or unstable. If a patient is hemodynamically unstable and the patient is presenting with hematochezia, as I told you earlier, there are very rare causes of the lower GI bleed which present with a medical emergency or profuse lower GI bleed. And then we have to look at that whether this bleeding is really from the lower GI tract or can be an upper GI bleeding. If there is a profuse upper GI bleeding which can trespass the stomach acid and prevent the contact with the stomach acid, this can present as hematochezia as well. So the number one thing to do is an upper GI endoscopy in a patient with hemodynamically unstable bleeding of the lower GI tract. You do an endoscopy to rule out whether there is an upper GI cause of this hematochezia. If you don't find an upper GI cause, then the next step is to do a colonoscopy. And then we are going to look at the various options in the colonoscopy. But this is an important point to remember in the context of the profuse lower GI bleeding, which can give hemodynamic instability. Because generally the patients which present with lower GI bleed are hemodynamically stable. They might have some signs and symptoms of anemia or dyspnea, but they are not in shock or they are not in hypovolemia as per se. There is very rare chance of these patients bleeding to that as compared to someone who has a bleeding varices. So this is one point which is different from the upper GI bleeding, the lower GI bleeding. Now, if the patient is dynamically stable, then what are the recommendations? The recommendations is if the patient is less than 40 years old, then you consider flexible sigmoidoscopy in these patients. You can replace the flexible sigmoidoscopy by colonoscopy if the patient has iron deficiency, anemia, or a familial colon cancer history, or there is large bleeding. This is because, as we talked about in the previous slide as well, that in the extremes of age, going onwards 40 plus or 50 plus, you can say, cancer becomes a fairly common cause of lower GI bleed, the adenocarcinoma of the colon. And this is something which we must rule out in that patient. So anyone above 40, or you can say 45 to 50 years of age, who presents with unexplained lower GI bleed, if there are no hemorrhoids, there are no anal fissures, and the patient says, I am otherwise fine, but there is lower GI bleeding, or there is some occult lower GI bleeding, like the patient has unexplained anemia, the patient has unexplained weight loss, the patient has unexplained syncope, dyspnea. You have done all the work up for dyspnea and syncope, and his chest is fine, his heart is fine, and you can't find out what is going on. Then you have to raise the suspicion of malignancy and colon malignancy very higher in these patients, and it is very important to rule out the adenocarcinoma. In such patients, if they are young, 30 to 35 years of age, flexible sigmoidoscopy is done. And if they are adults more than 40 or 50 years of age, then you do a colonoscopy. Now you have done colonoscopy. What are the findings of colonoscopy? If you have a identified point of bleeding and the bleeding stops, you don't have to do anything, because generally, as I told you, in 70 to 80% of patients, the bleeding stops on its own. If the bleeding site is identified, but the bleeding is persistent, then you do an angiography. And if you can't fix it with the help of colonoscopy, you do the angiography in these patients. You fix especially this is very much common because of in the context of some angiodysplasias or vascular ectasias or some vascular malformations of the tumor. You do an angiography and you fix that bleeding site. If the bleeding still persists despite the angiography, then the last resort to us is surgery. We do a surgery, and if that part of the bowel has been necrosed for a long time, then we can cut it and pull it out and form a loop and later on join them. So this is the protocol which we are going to follow in someone who has persistent bleeding. And you do a colonoscopy, you find a bleeding point, the bleeding is still persistent, you do an angiography. Angiography doesn't help, you go to the surgery. And what happens if the site is not identified and the patient still has bleeding, or the patient still has signs and symptoms going on? Then you can classify that as an obscure GI bleed, or a GI bleed in which you are unable to find an identified site of bleeding. And then we are going to follow the workup of the obscure GI bleeding in those patients. All right. Now, if we have gone through the upper GI tract with the help of an endoscope, and we have gone through the lower GI tract with the help of a colonoscope, but we are unable to find the site of bleeding. But the bleeding is still going on, or bleeding is persistent. Then we classify this as obscure GI bleeding or the hidden GI bleed. And what is the treatment protocol we are going to follow in this case? We are just going to go stepwise in this flowchart. This can be a slightly complicated flowchart, so I want you to just bear with me and go back in a stepwise manner along with me. Now, we have classified the bleeding as obscure GI bleeding. This can either be as occult or overt bleeding. As you know, occult means hidden. For example, the patient might present with anemia or hemodynamic instability, for example, dyspnea or syncope, but there is no visible bleeding. That is called occult bleeding. But overt bleeding means that there is bleeding going on, but you are unable to find the source of that bleeding. So we are first going to discuss how we are going to manage the occult bleeding, and then later on the overt part of the bleeding. All right. As I told you, it can be either occult or overt. If there is occult or hidden GI bleeding, you transfuse the patient with iron or give an iron tablet, or you can give a ferrous sulfate tablet to make him feel better or make his hemoglobin go up. And along with that, you are going to stepwise follow as follows. If the iron treatment is not successful, then you go and do the scope. You again scope the patient. You do an endoscopy or the colonoscopy to find out that whether did we miss any point in the first place, that the iron treatment is not helpful to the patient, and this means that the bleeding hasn't stopped, and whether we haven't missed anything, then we do a repeat procedure. But if the iron treatment is helpful, then there is no further workup needed, and the patient is managed conservatively. If the iron treatment is not successful, and on repeat scoping the patient, you find some positive area of bleeding, then this can be managed as in the previous slides, depending on the location of the bleeding, whether this is an upper GI or a lower GI bleed, whether we need to manage it with the help of a scope, if it is manageable, or if medical therapy or embolization with the help of an angiography, or surgery in patients in which the angiography or the endoscopy does not help. So this is the area which we talked about in the upper and the lower GI bleed. This is where we have to take these patients of the obscure GI bleeding. We start with an iron therapy. Iron therapy is successful, well and good. If it is not, we repeat the procedures and try to find a location point for the bleeding. Now we have again done the endoscopy and the colonoscopy, and this again comes out negative. We are unable to find the site of bleeding. Then we do a procedure called capsule endoscopy. We make the patient ingest a capsule, and this capsule goes all the way from your upper GI to the lower GI tract. This is specifically helpful in finding the cause of bleeding in the small intestine. As you know, there are some areas of the small intestine which difficult to scope. For example, the upper GI endoscope can go as far as the gastroduodenal junction, and colonoscopy can be done as far as the colon. So the small intestinal area is difficult to scope, and we can do it with the help of a pediatric scope, but that is a troublesome procedure. So we do what is called capsule endoscopy. With the help of a capsule, a radioactive capsule, it works as an endoscope, and as it goes down your GI cavity, we can have pictures of the various parts of the GI tract. We can look at what's the pathology going on, specifically in those parts which we are not able to visualize with the help of a normal scope. We have done capsule endoscopy. We have found a source of bleeding. We again revert to this area, a specific management, what we can do, whether we can embolize it or medically manage it, or we have to do surgery. That depends on the cause. But the capsule endoscopy is negative. Then you have to look at the further workup, the risk-benefit ratio, the analysis that whether this pathology is related to this anemia or this dyspnea is related to the GI tract or not. The further workup depends on the risk-benefit assessment or whether the other procedures like the pediatric endoscopy, small scoping the patient, whether that is helpful or not. If it is helpful and you see that the context of the patient will benefit from the procedure, then we go at the more complex procedures like the CT, enterography, the enterocolysis, the intraoperative enteroscopy used operate the gut and intraoperatively do an enteroscope to look at the various sites of bleeding, or a diagnostic angiogram. These are fairly advanced procedures, and these are reserved for all these patients who have a negative capsule endoscopy, but they are still symptomatic, and our medical assessment is these patients can benefit from all these procedures. If the risk ratio outweighs the benefits and you don't go into these advanced procedures, then you just observe and passively care for the patient, and you look at the patient fairly closely. You monitor his signs and symptoms on regular basis, or you schedule regular follow-up visits with such patients. And then depending on their clinical progression, these patients can revert back into the previous scope, whether the benefit ratio will outlast or the risk going forwards, then we can transform them into this department as well going forwards. But if at presentation the risk outweighs the benefits, then we don't do these advanced procedures in this patient. We have done advanced procedure in someone and we have found a source of bleeding. Again, we revert to this area of comfort of specific management. What are the various options we have, whether this is endoscopically embolizable, or we can do a angiography and fix this, or whether this is manageable medically. If it is not medical, if the CT angiography or these advanced procedures like the angiogram are still negative, then we have to look at whether the patient still has symptoms or not. If the patient doesn't have symptoms, then you can conservatively manage him with the help of passive care or palliative care. But if the patient has symptoms and these are troublesome and these can cause some life-threatening disease to the patient, or there is some threat to the patient's, this can cause mortality if your medical judgment says, then you go and repeat all the tests again, that whether we have missed anything or not. You can repeat the upper GI endoscopy, the colonoscopy, the intraoperative enteroscopy, angiography, or you can go through a nuclear scan as well. The nuclear scan is also a very helpful procedure, especially in the context of children. For example, if someone has a Meckel's diverticulum, then you do technetium scanning in those patients, and that technetium scan accumulates in the Meckel's diverticulum, and you can have a good diagnostic yield from that procedure. So this is the stepwise way we are going to go. If someone who has been managed passively and there is recurrence of this problem, then you can again revert to this repeat of the test, because this is the best we can do. We have gone through everything, but we are unable to find anything. Then we give it another shot and try to find out whether we have missed anything on the first place. And if we find anything on the repeat of the test, then we can fix it easily. No recurrence, no further workup needed. Just manage the patient conservatively. Now let's go on to the other side. If there is overt bleeding or visible bleeding, if the patient is currently bleeding, yes, then nuclear scan or plus minus angiography. You can do a quick nuclear scan to locate the site of bleeding, or you can do an angiography to localize it. And angiography is helpful more in this context because you can fix the bleed with the help of an angiogram. You can embolize the bleeding artery. If there is no active bleeding, but the patient had overt bleeding at presentation, then you can do a repeat endoscopy if this is an upper GI bleed, or a repeat colonoscopy if there is a lower GI bleed. But in the context of active bleeding, if you have found nothing, then again you revert to the colonoscopy or the endoscopy. But if you find something positive in the angiography or the nuclear scan, specifically on the angiography, you can fix it with the help of embolization there and then. So this is a fairly complicated diagram at first sight, but if you break it down step by step, like I have just done, this is fairly easy to understand and it makes sense at all the points. Just to summarize it, this is our area of comfort. We have to take every patient into this area where we have a positive visualization of the bleeding artery on the angiogram, or a positive CT enterography, or a positive colonoscopy, or a positive capsule endoscopy. Because when we have a bleeding area in front of our eyes, it is easy to fix rather than when it is hidden or occult. All right. After this complicated diagram, let's just talk briefly about what is fecal occult blood test. It is a test which is done for example, you have a 50-year-old patient, and the patient says that on his that I have a certain dyspnea or chest pain, or I don't feel well. Then there is no bleeding in the patient per se. But you suspect that you do a thorough workup of anemia, you haven't found anything. Then you do what as a screening test called a fecal occult blood test. This test basically identifies if there is some occult or hidden bleeding in the fecal sample. This looks at the hemoglobin levels or some blood products present hidden in the fecal sample, which are not visible to the human eye. If we found this test to be positive, this is a screening test, you can say, for gastric colonic adenocarcinoma. If we find the fecal occult blood test positive, but without iron deficiency, the patient doesn't have anemia, but and there are no upper GI tract symptoms. What we do next is the colonoscopy. The upper GI symptoms are not present, then the test is more or less indicates that this is a lower GI pathology. But if there is no iron deficiency, we go and do the colonoscopy. If we found a source, we treat as indicated. If it is a bleeding source, we can fix it. If it is medically manageable, we can medically manage it. If we don't find a source, then we don't evaluate that patient further until and unless that patient develops anemia or other signs and symptoms like dyspnea or syncope or something like that. So this is after the screening test of the fecal occult blood test, because you can't go on doing colonoscopy of every patient who is presenting with suspicion of colonic adenocarcinoma. This will be very troublesome, and this will be monetarily very difficult to manage for the hospital and for the patients as well. So that's why we have devised this screening test of fecal occult blood test. If this test is positive, then we go on further with our management. On the other hand, there is a positive fecal occult blood test and there are upper GI symptom present, like there is hematemesis or melena going on. Then you do both the upper GI endoscopy and the colonoscopy, because the suspicion of lower GI bleed is still present in these patients, and this can occur concurrently as well. So the upper GI endoscopy is done first, which is followed by colonoscopy. You have found a source, you treat as indicated. If you are unable to find a source, then you again categorize that patient in the same bracket as no further evaluation until and unless anemia develops. If that patient develops anemia going forwards, then you again do the colonoscopy and carefully visualize that all the parts of the colon, the transverse, the descending and the ascending colon, to look for any pathological changes or histological changes, so that we can catch the carcinoma in the earlier part and before it spreads out or metastasizes or causes havoc. Because if this carcinoma is caught early, we can easily manage it with the help of surgery and chemotherapy. But once it is advanced and it starts causing profuse bleeding or obstructs the colon or can metastasize, then it is difficult to treat it, and then we have to basically manage the patient palliatively or conservatively. So this was all about the gastrointestinal bleeding. It is a fairly straightforward topic, as you can see, if you go through it systematically and logically. I urge you to go through this lecture on your own again to have a complete and thorough understanding. I'm your educator, Dr. Lara Munir. Thank you for watching sqadia.com.